I am just astounded at the group of people around the table to talk about this issue, which I think speaks to how important the issue is.
Given health spending's growing and significant role in our nation's economic and fiscal outlook, that this is an important topic indeed. The Peterson Foundation is really pleased to be sponsoring the meeting.
The shortened version of our mission statement is to serve the public good to improve human health. While we have a center focused on bending the cost curve, we do have over 400 employees working on a wide variety of work. And I think that's relevant because that provides, if you will, a deep bench as you folks help us identify and define potential areas where we need to do work. We want to draw upon the full breadth of the Institute. Bending the cost curve has been selected as one of those critical systems issues. Large-scale pressing issues, what are the key research questions, and how do we really create valuable, pragmatic evidence, but then how do we channel it into action?
But this is kind of an amazing group. More timely monitoring and measuring of health spending and related economic indicators. Potential GDP is full employment. What would GDP be at full employment? So the Altarum health sector model is the output of that model is national health expenditures. And we always stay as close to the national health accounts as we can in all that we do. One way to have a higher sustainable rate of growth in health spending is to have a higher rate of growth in GDP. And to the extent that the healthcare system can create a larger, more productive, longer lasting, working into longer years labor force, you're helping the denominator in this ratio and essentially affecting what is sustainable.
And I'd like to thank Altarum for the opportunity to be here. It is a unique meeting. Payments that are more directly tied to what we want, better care and lower costs. But it all needs to fit together into creating an environment in healthcare that we don't have now, one that's more directly focused on value, where everybody, providers, consumers, payers, have much more sensitivity to both the quality of care and the cost of care that their decisions affect.
In most markets, there is a very important provider or more that has so-called must-have status. And the notion that exchange-based private insurance plans are likely to look more like Medicaid managed care plans than your typical employer-based plans. I actually believe that the tiered networks will be much more acceptable to consumers the way it turned out that in prescription drug benefit design. In other words, does the public want to become more active shoppers in healthcare, or would they rather regulation deal with these issues?
Joe Califano was extremely exercised about the unsustainability of the growth of healthcare spending, which had then soared to 8% of GDP and was projected to go past 10% of GDP, and that was clearly unsustainable. And we christened that transformed entity premium support. Little did we know at the time what legs that term would have, that the chances that the sort of plan we proposed would produce the benefits that we sought are close to nil. The protections afforded by traditional Medicare loom larger and larger.
The IPAB's a policy that those of us at the White House, really thought was very important economically. We went to the Senate and the House, begged them to include it. As you can see, as those of us have graduated from the White House, the support for this has not grown. The IPAB is 15 members who have a full-time job as government employees, which will make it hard to recruit, I think, for people that you want to do it. It also can never raise taxes, increase premiums, decrease eligibility to Medicare, or ration care. And while it's meant to take politics out by being kind of extra Congress in terms of its ability, the politics to actually have it work, I think really make it complicated.
So basically, to control spending, you can make patients pay more, cost sharing, a demand side strategy. You can do delivery system reform, integrate providers, change the way providers work in a sort of production function kind of way, emphasize primary care. Or you can do payment reform. How much you spend is just based on how you set the rates. If you have a global cap, You know what the spending trend is going to be. The question is, will groups be able to live under that global cap, and how you update it over time? Who, broadly speaking, is going to control spending growth, or as Charlie pointed out, basically use? Is it going to be consumers through the incentives they face? Is it going to be physicians through an incentives they face, which is basically what the AQC takes that view? Is it going to be insurers through a whole series of other activities that may involve pushing this down, some combination of that, or the government through regulation?
So my proposition is to consider some specific things, like preventable admissions or hospital readmissions, where, frankly, if the health plans and Medicare can reduce them by 13 to 20% compared with a base case, that's a lot. I was sitting next to Bob Reischauer, and he said, well, if you get every hospital as good as these good ones, every health plan as good as these great ones, you still haven't bent the curve, you've just done a one-time thing. And I'm like, yeah, Bob, but if we could, take a chip out of that one-time thing for the next 15 years, we would have bent the curve for 15 years.
This has to do with sustainability, bending the curve, and some comments that Henry and both Charlie made on that. And that is the ambiguity of the term sustainability.
Where you achieve efficiencies is in choices of plans in a competitive environment.
The notion that you can do it just by focusing on the supply and get it right in a way that'll be acceptable for people just seems to me not going to happen.
Who's the consumer anyway? Patients are consumers, but doctors are probably much more the decision makers. And I think the point of premium support, not talking about a specific proposal now, but the general point of premium support is actually to get the attention of the providers.
How we model and estimate the interactive effects of supply-side and demand-side interventions is a huge challenge.
Right. How we're going to deal with this, what I think we all realize is the original sin of health insurance, and it's not just public, it's private.
How do you overcome those kinds of incentives with programs that enable you to share in savings, but they don't essentially overcome these powerful incentives that fee-for-service have?
Massachusetts is now doing something which makes a lot of sense, and we'll study it. You'll study it, and we'll learn. But the point I want to make is California's been doing this for 20 years.
I love what you're doing with the data collection, the stratifications, really drilling down into the treatment and prevention and the modeling work. It seems to me we need more of that, and not just in Massachusetts, but nationwide.
Mike, I actually don't know how to bend the cost curve. But as you know, I spend a lot of time forecasting. Even forecasting bad things can be useful.
The managed care backlash was a major event.
A major part of the slowdown in 2004, thereabouts, was something already mentioned, that the rate of discovery and introduction of new pharmaceutical products fell like a stone. And we can slow the rate of growth of health spending if we just have less new technology. Does that make you happy?
We map that into the health accounts with a number of adjustments to align industries and add in self-employed and add in benefits.
Deductibles in employer-based insurance, if you look at all plans, have more than doubled since 2006.
Where we're either trying to provide a certain level of health care and minimize the cost to provide that care, or we're saying we're willing to pay so much for health care and let's maximize the amount of health care we can get out of what we're willing to spend.
It's the technology. And I think over the last 10 years, it's been a relatively tame period for technology diffusion.
I wanted just to encourage you to build on the work that we had done years ago on spending by condition.
What it is insurers might be good at or might not be good at looking over time. I don't think you could do this looking at 1 year, one set of filings or something. I think you have to follow it. See, is it price, is it utilization, by which kinds of services, where can they potentially be making a difference?
So I want to thank the folks from Altarum, Charlie, Paul, and everyone else. I want to thank Susan and the Peterson Foundation in general for their support of this effort, and thank all of you for wonderful comments. It really covered a lot of ground and addressed an important issue, so I certainly enjoyed listening to the comments. And so again, thank you.
Altarum Institute, a nonprofit health systems research and consulting organization working to improve health and health care. Altarum Institute, systems research for better health.